Hello, future nurses. I know last week was a busy week with exam 3 and then diving straight into unit 8 after. So I wanted to take a few minutes just to do a quick review. We know me, quick reviews probably hopefully less than an hour. But especially for those, there's some information I know we talked a lot about, but it's not clear in the book, but it's important information to know. And I know I have some auditory learners out there. So this covers 4 chapters, and we're going to start with chapter 27, anger, aggression, and violence. So when we look anger versus aggression, anger is the emotion, and it's normal and appropriate to be angry at times. Whenever we're threatened, whenever there's a challenge. Aggression is the act. So hitting, punching someone, calling someone names, verbally attacking, it could be different. A big point we talked about in class was the rate of, and we skipped over this little video, I'm going to skip over it now, but just the amount of violence that we're seeing in facilities is increasing, especially when we look at violence towards nurses. We're often the frequent target of violence as nurses because we have the most direct patient contact. Psych units, emergency departments, and our GERI units have the highest rate. These are all just, and I know we didn't watch them in class, but like videos that kind of talk about it. That's loud.
1, 2, 3, 4, 5.
So where we kind of see just this violence among healthcare workers being
Stop, nurses.
But it should not be. Some of the things we see that go along hand in hand with anger and aggression, PTSD, substance abuse, bipolar disorder, all we see increased depression. Having a mental illness does not necessarily make you more aggressive, but some of those serious mental illnesses. So individuals who have bipolar and they're in that manic phase for a prolonged period, or individuals with schizophrenia, especially paranoid schizophrenia, do tend to be more anxious. We do see anger and hostility affect our physical health. If you are angry for a long period of time, it increases your risk of hypertension, cardiovascular disease, so stroke, heart attacks, all of those different things are increased. When we're just angry, our heart does not like it. Etiology, if we look at it, we do have biological factors. We do see different ways of how electrical activity goes in the brain, different amounts of neurotransmitter. Serotonin is our neurotransmitter a lot of times for anger. We do see anger more so with some neurological conditions, Alzheimer's, frontal lobe injuries, traumatic brain injuries, dysregulation in the amygdala. So we do have a whole bunch how the hippocampus comes into play for prefrontal cortex, all sorts of different things. When we look at our theorists, we learn from those around us. If we learn from our parents, if our parents are aggressive, we learn from playing video games, all sorts of different things. When we look at the nursing process, this is what we're going to see in our patients if they are manifesting anger. What are we going to see in their behavior? Increased demands, irritability, frowning, redness of the face, pacing, clenching or unclenching the fists. So we have to be able to identify, see those behaviors, get ahead of it. We need to look at their history. Trauma-informed care basically says that everyone has a history of trauma. And as healthcare providers, we need to try not to re-traumatize them. We have to go through that. Self-assessment is important because if you're getting yelled at, it's really hard to stay calm. And we need to look at our choice of words, our nonverbal communication, our body posture, facial expressions as we are dealing with these patients. Our nursing process, these are some common nursing diagnoses that we are going to see. They're pretty straightforward: self-directed violence, other directed violence, ineffective coping, we're too stressed. So when we look at it, our outcome identifications are going to be based on whatever our nursing goal is, whatever we want for our patient. Intervention needs to begin before any sign of escalation. We have talked ad nauseum. We have gone over it so much: primary, secondary, tertiary prevention. We have to do primary prevention. We have to do secondary prevention. We don't want to be doing tertiary because tertiary means it's already happened. So we have to develop a relationship with the patient. Have those conversations. Talk about the weather, sports, like food, whatever's of interest. Let the patients know what's going on, acknowledge their needs, stay on top of their pharmacology, have that non-threatening manner, that calm exterior. Give that personal face. You want to stay arm's length double away. So basically, what I was always taught, if the patient puts like their leg up to kick you, you want to be 2 legs away, or at least a leg and a foot away. Have an escape route. Don't take the words personally. They're not always mad at you. They're mad at the situation. They're mad at everything else that's going on. Slow, short sentences. Don't yell. Calm voice. Open-ended statements. Don't end sentences with okay. Because if you end a sentence with okay, it's kind of condescending. Pay attention to the environment. Get everyone else out of the way. Make sure there's no weapons in the area. All sorts of different things that we've talked about frequently throughout the quarter. Again, staff considerations. We don't want to have scarves. We don't have necklaces. We want to make sure we have enough staff for backup if we need it. 2 and 6 to me can be very confusing because 2 says ensure there's enough staff for backup. 6 says avoid confrontation, especially with a show of support. So we want to go to the patient, but we never want to go by ourselves. We want to make sure there's someone keeping an eye on the situation. A show of support is like, I'm going to call security, I'm going to call and get like 10 other people, and this giant group of us is going to go confront the patient. You don't want to do that, but you want to make sure there's someone who is either with you or keeping an eye on you, who knows where you are. Know the layout so you know how to leave. Don't block the door. You want to have access to the door, but you also want to make sure the patient knows how to leave, because if you corner the patient in a room, they can get more aggressive. And then provide feedback. Hey, I see you pacing. Are you angry about something? To just start that dialogue. We really do just want to make sure we're responding to that aggressive client as soon and as early as possible. Pharmacological interventions, the B52 is that cliche classic. I have actually quite a few t-shirts that talk about B52s on it. Nursing t-shirts. So 50 of Benadryl, 5 of Haldol, 2 of Ativan. I have seen upwards of 20 Haldol, 4 of Ativan, some type of mix. We may do something different depending on what the patient can or cannot have. But this is generally what it is. We are a role model. We're an educator. So we want to educate the patients on coping mechanisms. We want to educate them on de-escalation, self-soothing techniques. We want them to identify triggers. We want to be able to coach them and work them through it. We want to be proactive. The biggest thing to think of when we look at this is that teamwork and safety and that use of seclusion or restraints. Legally, most courts are going to hold that seclusion and restraints can only be implemented when a patient creates a risk of harm to self or harm to others. No less restrictive alternative is available. So that means we've tried our less restrictive alternative. They're not going to work, or we can't for whatever reason, then we can use that seclusion or restraints. There are plenty of different guidelines for the use of these restraints. Seclusion is putting the patient alone in a room. Restraints is any method to tie the patient down, to restrict their freedom. If you are just holding a patient, that could be considered a restraint. If you're standing in a doorway blocking them from leaving a room, that could be considered a seclusion. Generally, seclusion is considered least restrictive when considering seclusion versus restraints. It may be helpful in reducing sensory overload. We don't want to use this punitively, but we do tend to go to seclusion versus restraints. Some different things to do or to consider. Why are we using the restraint? This is pretty much coming from box 27.3, page 512, I think, in your book. Why are we using it? What happened? Danger to self or danger to others? We have to look at the legal requirements. The amount of time our patients can be restrained is different. An adult can be restrained or in seclusion for up to 4 hours in the state of Texas. Pediatric patients, depending on their age, 1 to 2 hours. Some facilities say restraints are max 15 minutes because they don't want you to hold the patient for long. They want you to hold them long enough to get them into seclusion. We can, as RNs, restrain our patients without an order. However, we have 1 hour. So one of the most important things legal when we're looking at some of these Legal and documentation are going to be some of our two most important. After restraint, we get a patient restraint. As a nurse, the next things we're going to do, call the doctor to get an order. They may not answer their phone, so sometimes you may have to call them more than once. So call as soon as you can. Do not wait till an hour. You have an hour, but don't wait to an hour. But call and start that order process, and then you document. We have to do an assessment on the patient. That is extremely important to make sure that we're backing up, one, why did we do the restraint? And two, was there any harm to the patient? Did the patient get hurt? So calling the doctor for the order and our documentation, assessing the patient. We have to have a one-to-one, but it will not always be the nurse. Assess as the nurse every 15 minutes. There are some reasons we do not want to seclude or restrain the patients if they're unstable medically, COPD, pulmonary disease, spinal injury, seizures, pregnancies, if someone is deaf. If we have a patient who is deaf and cannot communicate except for via sign language, we do not want to restrict the movement in their hands because then they cannot communicate. So we do have to be cautious. If we have someone who is overdosing on drugs, we don't necessarily want to restrain them either. They need that order, but like I said, we have 1 hour. We do have to take into considerations hydration, toileting, nutrition, comfort. So that does come into play. We do need to offer food, fluid, and water throughout it. Releasing the patients as soon as they're calm, we have to release them. If your patient falls asleep, you have to open the door or untie them. Generally speaking, we're not just going to let them up at once. We're going to be like, hey, if they're in seclusion, go sit in the back corner. They're going to be sitting in the back corner. We're going to open the door and tell them you're going to sit here and we're going to have a quick conversation. And if they can sit there and have that conversation with us, then they can exit the seclusion. Same thing with restraints. I'm going to untie like one leg, give them 10 minutes of talking to them, then go to like the next leg, and we're just going to keep going between it. Your book talks a whole bunch about different settings. Patients in a general hospital setting, there is a difference between medical and behavioral restraints. Medical restraints are not as restrictive as behavioral health restraints. So we do have to think about that. Just because someone's on a medical unit does not mean that they cannot have behavioral health restraints. So you have to realize why this patient's being restrained. When we look at some of these different ones, coping skills overwhelmed, patient loses autonomy when hospitalized. And that alone can create a lot of stress, a lot of uncertainty, a lot of anger. So we just need to make sure we're talking to them, making sure we understand their needs, making sure we're providing like comfort items. We don't want to be ambiguous. We want to be clear, make sure we're communicating well. If we do have a patient with like a cognitive defects, we never want to reorient. We want to orient, but not reorient. Patients who do get confused, some disoriented older patients, they just don't always know what's going on. We always tend to think in good examples like our Alzheimer's patients. If they don't know, and this is more that cognitive deficits, if they don't know what's going on, you don't want to be like, if they're like, oh, talking about the 70s, you don't be like, no, it's like 2024, your kids are like grown-ups now, because it can just make them more agitated. So we never, ever, ever want to reorient. Child, older adult, intimate partner violence. We have different types of abuse. So this is going into the next chapter. Physical abuse, sexual abuse, emotional abuse, neglect, and economic abuse. We talk a lot about those on the next few slides. I went too far. So we went through these in detail in class. Physical abuse is generally speaking pretty straightforward, right? Harming someone, driving recklessly in a car, forcing you to use drugs, anything that will physically hurt you. Emotional abuse is anything that's going to make you feel bad. Gaslighting is one we tend to nowadays have a good explanation of what is gaslighting. Withholding in affection, humiliating you, calling you names, controlling you. I should never have had you. I should have had an abortion. Especially grandparents, if we have an elderly individual in the home, I should just put you in a nursing home. I don't want you here anymore. So we see all sorts of different things when it comes to emotional abuse. Sexual abuse and coercion does not just have to be rape. Forcing you to watch porn, giving you drugs to try to loosen you up, pressuring you, reacting negatively, if you're, don't want to have sex. Forcing, it could be forcing you to sex, calling you sexual names, forcing you to dress in a way, a whole bunch. Financial abuse, um, we see this a lot in elderly and in adults, especially if we're talking about intimate partner violence, taking your money, not contributing, preventing you from having access to credit cards, bank accounts. That first one, giving you an allowance and then watching how you are spending it, accounting for every cent that is being spent. We see this frequently in the elderly, where caregivers are using their money. Granddaughter is going to use grandma's money for whatever she wants because grandma doesn't need it anymore. She's about to die. Digital abuse is kind of a newer one. Who you can't be on social media with, not letting you be on social media, talking about you on social media, sending you inappropriate things, making sure they have access to your accounts, checking you, monitoring your location and where you're going. So half of all Americans have experienced violence in the families. Girls are only slightly more likely to be abused at 51%. Younger children are more vulnerable. We talked about a lot of the statistics in class. They're just really super crummy. When we look at that comorbidity, we have those secondary effects of violence. If someone is being abused, they are more likely to have anxiety, depression, suicidal ideation, major depressive disorder, PTSD. We talked a lot about our ACEs, our adverse childhood experiences, and how those contribute to physical effects throughout the body. To have violence, we need a few different things. A perpetrator, someone who's committing the violence. We need a vulnerable person, someone in the family who is getting the abuse perpetrated to them. And then we need that crisis situation, something that makes this happen. So when we look at the characteristics of perpetrators, some of this comes from box 28.1, characteristics of abusive parents. In class, we talked about Joe from You. Their needs are more important. They don't have the social skills. They're very jealous. They may be controlling finances. We do tend to see a history of a substance abuse. Pregnancy increases violence, low self-esteem, poor coping skills, history of mental illness, violent temper, and outbursts. We have a ton, feeling of little or no control. When we look at the cycle of violence, we do have a few different stages. The tension building stage is kind of where it starts. We're just kind of waiting for this time. The victim could be ignoring the effects of previous behaviors because they don't want it to escalate. The abuser's kind of rationalizing their behavior. Some researchers say that the abuser may try to decrease that tension with drugs and alcohol. In the acute battering stage, that's kind of where tension peaks and something happens. There are some experts who believe that the victim may actually provoke the incident because there's so much tension and fear in this tension building stage. So there's so much fear in that tension building stage, and the victim is like that walking in eggshells. They're so helpless, and they know that if something happens and they just get it over with, they can move on to the honeymoon stage. And in the honeymoon stage, everything's good. He's bought me flowers. He loves me. He's super kind. He tells me it's never going to happen again. And anything that they've wanted. So if they were planning to leave in this tension building stage, they get to the honeymoon stage and he loves me. So any plans to leave that may have been initiated previously are abandoned in the honeymoon stage. But the cycle repeats itself over and over again. We do have some characteristics of vulnerable women, pregnancy, especially white women. Violence may escalate when they're trying to leave. If you leave the relationship, this individual, those thoughts that they had, if we went back a few slides, their own needs are more important. They tend to think this is like the best relationship ever, that jealousy. So when we're trying to leave, it just explodes. If they want to get a job or they want to have their own finances and they used to not do it, it made it worse. If we're looking at children, younger children, especially less than 3, kids who are different, autism, ADHD, Down syndrome. Last 3, to me, kind of group together, especially when we see that overturning of Roe versus Wade, if we do have an unwanted pregnancy, it may increase the risk of violence to that child. If the child reminds the parent of someone they don't like, an ex-husband, or maybe the parent was raped and had to carry this child to term and decided to keep it, but that child now just reminds them of. If there's anything that interferes with the bonding between the parent or child, mental illness in the parent, substance abuse, medical issues, all sorts of different things. Our older person, poor mental, physical health, especially if we look at Alzheimer's, dementia, anything that cognitively affects it. If the older adult is dependent upon the perpetrator, so we're talking about like a caregiver type relationship. A female older than 75 who is white and living with a relative is especially if they have Alzheimer's, is one of our most at risk. That elderly father being cared for by the daughter he abused as a child, and an elderly woman who's cared for by a husband who was abusive to her in the past. When we are screening and assessing these patients, we have to look for all patients for possible abuse. That's secondary screening. When we go to the hospital, we go to the doctor and they ask you, do you feel safe at home? That is a secondary screening. It gets asked of everyone, regardless. Symptoms can be very vague. They could be somatic, chronic pain, insomnia. We have to look at the process. We have to look at the setting. I always laugh because I take my kids to the doctor and they're like, do you feel safe at home? And they're asking this of my 8-year-old while I'm standing next to him. Statistically speaking, I am more likely to be the one abusing that child as his biological mother than anyone else. So if we do suspect some type of abuse or trauma, we have to ask the patient alone. We want to somehow separate them from the person we suspect is abusing them. We do need to look at sexual abuse, family violence, drug use. It should be completed alone. Sit near the patient, give them time. If we're talking about parents, how are there disagreements in how the children are disciplined versus, abuse or violence. Box 28.2 in your book, page 525, talks about those interview guidelines. Self-assessment, we don't want to have our thoughts, emotions, feeling cloud our judgment. We don't want to be angry. We don't want to be fearful if we're talking to someone and we are doing this. We don't want to have that blame the victim mentality either. Torso, ears, and necks, 4 and younger is just kind of an acronym because that intends to be where we see a lot of that trauma in children. And again, any bruising, if a baby is not pulling up or walking, is very unlikely. We want to, when we're doing assessment, we want to let the patient tell their story. We don't want to interrupt them. Open-ended questions are less threatening. How do you solve problems? How do you and your spouse discipline your child? Tell me about what happened for you. Who takes care of the children for you? What happens if you do things wrong? What do you do for fun? Do you have time for yourself? So we do have a lot of those different questions. We have to look at the violence indicators. We have to look at anxiety, support systems, suicide, drug and alcohol use. All of those things can come into play. We have to assess for safety. We have to assess for suicide. Those will never, ever go away. If the patient's not willing to answer, we don't necessarily want to force them. You don't always, and you want to make sure you don't want to have a group interviewing a patient, especially if it's traumatic. You want to have a minimal amount of people. So our nursing diagnoses, if we're talking about this injury, violence, physical abuse has ended, emotional abuse has ended, financial, sexual abuse, whatever has ended. Planning, we cannot tolerate abuse. We have to make these long-lasting changes. These are not little things. Implementation, we have to report. We have to prevent. We also have to report. This is going to be per state. They have different rules. I want to say it's 24 hours in Texas. I can never get this right. Numbers and we know do not mix. It's a 24-hour hotline, but we have to report. We're mandated legally, child and vulnerable adult. If we have a completely with it 25-year-old female who is a victim of intimate partner violence by her spouse, we cannot. Oh, my notes say 48 hours. That we have no longer than 48 hours to report. We want to counsel our patients, make a safety plan. Where can you go? We may have to have them memorize a phone number. What are you going to take with you, right? Bring your meds, bring your important documents, bring a change of clothes. You do not need your toothbrush. You don't need a hairbrush. Those things they'll have for you. But especially if we have a patient, let's say they're diabetic, we want them to bring their diabetes meds. We want them to bring their driver's license or their birth certificate if they have it, because it's just easier. Case management works a lot with linkage, getting them into it. It can assist the patient in kind of coordinating care. We want the patient to be able to do self-care activities. We need to do self-care activities. And then across the board, we will always talk about health teaching and health promotion, recognize behaviors and situations that might trigger violence. So again, we've talked about prevention of abuse. Primary prevention are what we're doing to prevent it. So increasing social supports, teaching resiliency and coping skills to kids, having all of those different things. If we write primary, we see removing risk factors. So if we're talking about removing risk factors, substance abuse programs, because if we cut down on substance abuse is a risk factor for abuse. So that then decreases it. So support systems, coping skills, substance abuse, decreasing those will decrease abuse from even happening ever. Secondary, we want to detect it early. So those are those questions. Do you feel safe at home? Doing those screenings. Tertiary, when we're talking about what is tertiary, the violence is happening, but we want to make sure everyone is going through that rehabilitative process, getting that long-term support, feeling better. So tertiary support could be referring a patient to a support group, to a self-help group. It could be, if we're talking about tertiary support, if we have a patient who has mania or schizophrenia and they become violent without their medications, but because of their disease process, they cannot remember to get their medications. We want to make sure they have the resources to get their medications and stay on the medications. So we have a bunch of different things that we can do. Advanced practice is going to be a lot of therapy. That's kind of always the case. This is your specific guidelines from the Texas Department of Family and Protective Services, what you have to report when you have to do it. A study, we kind of skipped over it. So Chapter 29, sexual assault. So if we're talking about sexual assault and violence, unwanted sexual advances or sexual harassment, we have many, many, many different types. A stranger, someone you don't know. Marital rape is within spouses. We always get that question. Your husband, your wife, your whoever partner cannot force you, regardless, to commit a sexual act if you don't want to. Date rape from someone we know. We'll talk a little bit more about drug-facilitated sexual assault. GHB, Rohypnol, ketamine are all different things. Someone gets drugged, they don't remember what happened. Incest within the family. Human sex trafficking is a huge one, and nurses generally are the ones who have access. We're the ones who see these patients. And then female genital mutilation. If I cut off your clitoris, you will not have sexual pleasure. So I'm going to do it. So what is rape? Rape is any non-consensual activity. It is generally considered penetration, vagina, anus, or any object, any body part. Oral penetration. So this does not necessarily have to be traditional, like sexual intercourse. It is not always necessarily penis into vagina. It could be, I'm going to take whatever this object is and shove it up you. It could be, right, vaginal, anus, or even oral. So it is the second most violent crime. We do have two different types, completed or attempted. Completed is defined as some type of penetration. Well, attempted is maybe there's a threat, or someone was going to do it, and then someone else walked in the room and caused it to stop. So we do have, if we look at statistics, every 73 seconds, an American is sexually assaulted, 1 in 5 women, 1 in 71 men. However, when we look at it, most of these are not reported. So those numbers are probably off. 12-month prevalence looks at partner rape as nearly 9% of females and 1% of males. Almost half of female victims have been raped by an acquaintance, so someone they know. So when we look at those relationships, again, spousal rape or marital rape, however we're going to call it, or acquaintance or date rape is generally someone you know. The perpetrator is nearly always male in these cases, but that does not have to be. When we look at the psychological effects of sexual assault, depression, suicide, anxiety, like fear, all of these things, we think back to like PTSD, those intrusive symptoms, memories, flashbacks, distress. You smell something. Maybe the individual wore cologne while they were raping you, and sometimes you smell it, and it just takes you back to that moment. Negative thoughts of mood or feelings. Remembering the traumatic or inability to remember, disassociation. Avoid things that remind you of it, and just that kind of hyper arousal, always being on alert. Incest comes a lot kind of with the same. We do tend to see substance abuse, eating disorders, personality, that negative self-images. We do have some special nurses, our sexual assault nurse examiners. They are a type of forensic nurse. This is an RN. You attend a 40-hour course. You get extra training in being how to assess these patients. Generally speaking, it's about a 4-hour assessment. These nurses are generally on call, and they get called into the emergency room whenever a sexual assault patient comes in. It is not just knowing how to medically perform this exam. There's a bunch of psychological things that we're going to think of, as well as chain of custody, being able to appropriately look at the samples that you're taking. If we're doing this, we do have to secure samples. There is a whole bunch of things that we're going to want to think about as that sexual assault nurse examiner. If we are looking at this patient, we're one, assess the level of anxiety, coping mechanisms, support systems, their trauma, emotional and physical. However, and again, we talked about this a lot in class when we had these best practice guidelines. Y'all were kind of all over the place. The very first thing we're going to do, even before we get to this examination, is develop a therapeutic relationship. We have to develop a therapeutic relationship with the patient before we go do this forensic exam. This is going to be a very invasive exam. This patient has already lost all their autonomy. It did not matter how many times they said no or what happened, or maybe those date rape drugs. They were unconscious. Someone drugged them and they have no memory of what happened. And they just woke up like naked and alone and completely abused. So we have to develop that relationship with them before we dive in. I know I said in class, and it's a very crude way to say it. It's not like, hey, I'm Julie. I'm about to do this exam. Let's spread your legs so I can go check your cervix with the speculum. We have to talk through them. So we have to develop a relationship. We have to explain in detail what the exam is. We have to get that informed consent. We want to stay with this client. You don't want to have multiple people present as we are doing this exam because, like I've said, it is very invasive. And we're going to tell them every step of the way what we're doing. We're making those detailed word choices. I need you to sit on this exam table. We are not going to call it a bed because we don't want them to correlate this exam with their bed at home or even with the bed they were raped on. As we go through this, we're going to develop that relationship. We're going to explain what's happening. Then we're going to collect the evidence. If the patient says no, we cannot try to force them. We know if they want to press charges, we need this evidence. We need to secure the samples. However, we're not going to try to coerce them because someone probably did just coerce them. And that coercion is probably what led to the rape, which is probably what led to them being into the facility with us. We do have to go through all of this. One separate that is also not on here. We talked about it separately when we looked at that table in your book with our date rape drugs. If we have someone who has come in and we can assume that they have probably been drugged. Their friends are like, we don't know what happened. She's only had one drink and she didn't finish it, but she's now fall down drunk. And it does look that there has been sexual assault. We do have to figure out what was taken or what was she given, because she may not have always. What did you ingest and why? Especially if this patient is unconscious, we need to know. We do need to also remember if our patient is unconscious and they have ingested, willingly or unwillingly, some type of substance, especially following this rape, we have to keep in mind airway, breathing, circulation. A lot of the things could cause seizures, but our biggest priority is going to be puking. Some of these things can make them vomit, so we want to make sure our patient is in that side lying position if they are unconscious, because we don't want them to choke on what has happened. And all of the samples are for legal evidence, so we do have to follow that chain of custody. When we look at that nursing process, we do have our own specific nursing diagnosis called rape trauma syndrome. It is defined as a sustained and maladaptive response to forced violent sexual penetration against the victim's will and consent. When we are looking about our outcomes, specifically to sexual abuse and assault, we look at that healing process, both physical and psychological. So when we think about what we might see, your patient maybe verbalizes that they have the right to be protected from abuse, especially maybe if they're coming from a long term, if we're talking like incest, and they just grew up like that, and daddy always did this. Like, I'm worthless. They might show that they are healing by verbalizing, I have a right to not be abused. We can see the healing of physical injuries. We can see a relief of anger and feelings of empowerment, feeling comfortable in relationships again. Interventions that we might do: counseling, promotion of self-care activities, case management, talking about feelings, talking about what's going on. Remember, when we're doing any of these, we want to avoid those cliches. I have said this repeatedly in multiple things throughout the quarter. No cliches. Cliches are always bad. Oh, you'll get over it will never be a good thing. We don't always know what is going on with the patients. We cannot victim blame. We cannot be like, oh, well, this happened to me when I was younger and I got over it, because it's never the same. Link them up with case management. There's psychotherapy, all sorts of different things. Evaluation, free of those signs and symptoms of acute stress, PTSD. They're sleeping through the night. They're going out with friends. They're having social relationships. Forensic nurses, we more so just went through the different roles that we see. We do have the International Association of Forensic Nurses, and they kind of go a lot of looking at that safety, the culture, the empowerment that we can do after some type of trauma. They kind of tie in and do a lot with that trauma-informed care. So what is forensic nursing? We are caring for crime victims and perpetrators. We may provide consultation. We may do court testimony. We may work in the correctional setting. We may work with inmates. And we have a few different roles depending on your education level. So a forensic nurse generalist is going to have the bachelor's degree or lower. The advanced practice forensic nurse has a graduate degree, and they are usually specialized in something. We also may have a doctor of nursing or a PhD. PhD tends to be more research-based, while our DNP tends to be more in practice. So what are the roles of the forensic nurse? Identify victims, treatment plans, collect evidence preservation. I don't know why I could not say that word. So we've talked a lot about our sexual assault nurse examiner already. So you did a SANE course. You went to a 5-day, 40-hour training. Generally speaking, that preceptorship, there's all sorts of other guidelines. So you have to see it's a 40-hour course, but you need 300 hours of practice to be able to be a SANE nurse. And we kind of go through all of those. Those are pretty much what we've talked about already. Nurse, coroner, death investigator. How did someone die? You're going to look at, it's kind of, most of us know what a coroner is, but most people don't realize you can also be a nurse and do this. So autopsy, symptomology, toxicology, pretty much just what caused this to happen. Forensic psychiatric nurses, competency evaluators. Again, don't get into the weeds. What is competency? It basically is that, can someone stand trial? We can help do assessments to make that final, and we'll talk about that a little bit more, but again, don't get into the weeds about competency. So these are the different ones we're going to talk about. The one that is not on here is a psychotherapist. So basically talking to the patient, doing that therapy to determine, to just help a patient or determine what did happen. So when we look at these, this is kind of goes into that legal sanity versus insanity. Actually, Andrea Yates is a good case. I don't know if some of y'all remember, some of y'all were babies back in 2002. Andrea Yates killed her kids, but it was a case of postpartum psychosis, and it was legally insane. So if you are sane, you can distinguish right from wrong. If you are insane, you have a major mental disorder, and you cannot establish what is right or wrong. And honestly, this goes back, that McNaughton rules goes back to 1843. Irresistible impulse, you knew the behavior was wrong, but you physically could not, for whatever reason, control your behavior. And that's that competency evaluator. That is what they're going to do. You could be guilty but mentally ill. So we have decided, Jess, you have done it, but you're just not in your right mind. So you more so get treatment, and then you are subject to the correctional system's parole decisions, not necessarily medically. Competence to proceed, if you are not psychologically competent, if you're not there, you cannot stand trial. So there are some individuals who are waiting treatment just to be able to stand trial. They have not gone to trial yet. Factor and expert witnesses, there was a lot of questions about this. You don't have to be a specialist, any one of us. I can go be a fact and expert witness. Well, Julie's a psych nurse. She's been a psych nurse for over a decade. She knows a lot about psych nursey stuff, about nursing documentation. We have a case that's going to trial. Should this nurse have restrained this patient? And then I, just as a nurse who has worked in that designated area of mental health, could go and act as a witness at trial. Well, the nurse did this right, or the nurse didn't do this right, or well, a nurse should have done this. Hostage negotiator, kind of just what it sounds like. You assist law enforcement. You look at the mental status of the perpetrator. You provide a linkage. You assess the hostages. Assess the stress level of the hostage negotiator. Maybe it's a bad situation and the hostage negotiators are all over the place and we're like, dude, you need a break. So a lot of different things. Communication with law enforcement, doing some training with them. Criminal profile, I always think of whatever that TV show is, Criminal Minds, maybe, where they're able to be like, this person was killed by someone who is 5 foot 8 inches. They weighed 175 pounds with a size 9 shoe, and they had blue eyes and brown hair. Their favorite sport was like basketball, and they can tell you all of these different things about the individual who may have committed a crime. Correctional nursing, you are a nurse who works in the correctional system. So you work with inmates. Yeah, that's pretty much it. That is it for this chapter, or for these 4 chapters. I know there's a lot to them. We went over them pretty much in detail in class. This is a kind of just brief overview about kind of what is happening and what we see, because I know it was a lot for these patients. If you have any questions about any of this, please reach out and let me know.